I'm going to be speaking about the emerging role of rectal spacers in the utilization, especially for high dose or dose escalated radiotherapy, and the potential impact that it's already had in this group of patients. And my disclosures are relevant as I am a consultant for Augmentics. If I could have the next slide. Great. So the question really is this an issue where we need to reduce the volume of rectum exposed to high radiation doses? We're really doing that with the emergence of intensity modulated radiotherapy, image-guided radiotherapy as well. So is it a problem in 2019? And the answer is that it is a problem. If we look at randomized trials, and these trials are very important ones that have changed a standard of practice throughout the United States. While typically radiation programs have been external beam radiotherapy programs have been 9 to 10 weeks of daily treatment. These trials, non-inferiority trials in general, have shown that overall there are no significant differences between these group of patients, at least in terms of PSA relapse-free survival, when we give these shorter courses, and I'm talking about shorter courses, which is known as moderate hypo-fractionated regimens, generally bringing it down from 10 weeks to 5 or 6 weeks, in these 4 very important trials at least. But interestingly, if we look at late grade 2 rectal toxicity in the right-hand column, you can see that rectal bleeding, while not predominant in 30–40%, but still it exists. And even in both arms of these trials, you can see overall the incidences of double digits, 14% versus 12%, 18% versus 22% in this Hypro trial. So grade 2 rectal bleeding is still an issue. Most of the cases with conservative management, these gradually heal up, but it still takes time. And then when you look at ongoing randomized trials evaluating the ultra-hypofractionated or SBRT regimens as well, this is what's being studied right now, and we won't have the answers for a number of years until these trials finish accruing and mature. But still, this is the delivery of very high doses of radiation, and we would anticipate that the rectal bleeding rates will be at least the same as what the prior trials had shown, maybe even higher. We looked at this slide already before, which is the ASCENDE-RT trial, a randomized trial comparing combination brachytherapy and external beam radiation versus external beam radiation alone. In both arms, 12 months of hormones were delivered. And again, we can see that with combination regimens, the incidence of even grade 3 rectal toxicity is noted, 3.2% in the external beam radiation alone, and in the combination therapy, 8%. And these are toxicities such as ulceration or any toxicity requiring transfusions or the like. And so rectal bleeding represents a clinical issue, especially in the setting of our delivering high doses of radiation. So I'd like to just share with you this video of a patient who is undergoing a rectal spacer. Here, transperineally, we basically place a needle between the prostate and the rectum in that space right there. And generally, once you are there and you are mid-gland, and I think people who have experience with brachytherapy have a much greater comfort level at doing this, but urologists do this, we are able to see where that needle is directly centered, and by moving to the axial image. And now we're able to hydrodissect by just putting normal saline in, creating that space. And as you can see, this space, the hydrodissection goes back and covers very well the apical regions as well. Once this space is created, then we would inject the basically the polymer, the hydrogel, into that space, and it creates about 1 centimeter to 1.5 centimeters of the separation, a separation that would really allow dramatic reductions in rectal exposure or dose. Then we could confirm this by looking again at the sagittal image, also at the axial image there, and this is all the spacer separation moving all the way to the apex. And then when we really best seen on an MR, this is basically the area that is created by the spacer. And so a randomized trial was performed in the US, and the longer-term outcomes have been reported by Dan Hamstra. And this is a 2-to-1 randomization where patients were treated with conventionally fractionated external beam radiation therapy. Some were treated with just fiducial markers. This was a blinded study. And some were treated with the fiducial markers in place, and at that same time of the placement, a spacer hydrogel was inserted. And so with this 2-to-1 randomization, patients were followed, and they were followed also with quality of life assessments, assessing bowel, urinary-related toxicity, and sexual morbidity. And this was what was reported 2 years ago or so in the Red Journal, where it clearly demonstrated that between the two arms there was a substantial and greater reduction of the volume of rectum exposed to the high doses, more with those who had the hydrogel spacer compared to the control group. And these were significant all along the way for various rectal dosing parameters or metrics which we routinely use. And this translated as well 3 years later. I mean, initially there were no real significant differences, but as we followed the patients, especially at the 3-year point, was emerging differences in terms of rectal toxicity, grade 1+, or specifically for grade 2 rectal toxicity. These were significant differences between those who had the hydrogel spacer versus those who hadn't. So not only were we reducing the volume of rectum exposed to the high dose levels, but this also translated into reduction of toxicity. And here we could see this here, a randomized trial of, in this group, in this trial, the bowel quality of life parameters, as you could see here, really the changes start to manifest after the 2-year point. And this was highly significant, and other metrics of bowel quality of life, again, noticeably different as well. Interestingly, and we're still, even in our own experience, trying to better understand it, but in addition to the reduction in rectal toxicity, this trial demonstrated a reduction in the incidence of low-grade, so to speak, urinary incontinence, much lower with the spacer group compared to the control. And this, I think, needs to be better understood, and I think I have spoken to Dan Hamstra, who is, again, trying to look at the data and retrospectively, at least in this randomized trial, trying to better understand what are the geometric impacts that could have caused a less dose either to the sphincters or the like, leading to urinary incontinence, less urinary incontinence. So the spacer placement is routinely used at our institution when we deliver dose-intensified radiation. And that is when we utilize combination therapies, or all of our SBRT patients at our institution routinely get spacer placement, and in selected cases for salvage brachytherapy as well, where there would potentially be a significant advantage for reducing the volume of rectum exposed to the high dose levels. Here's a case of seated prostate, and again, the placement of the hydrogel here really eliminates dose to the anterior rectal wall. One of our fellows, who's now in Toronto and practicing there, was the first author of this paper where 79 consecutive patients who underwent brachytherapy and had the hydrogel spacer placement. And this was monotherapy, combination therapy, or salvage monotherapy as well. And it achieved basically what we anticipated and what had been shown already by the randomized trial, which is known as this pivotal trial, that demonstrated this in patients getting conventionally fractionated external radiation. So as we tested this for LDR brachytherapy, we demonstrated that there was significant separations achieved between the prostate and the rectum, at least 1 centimeter, and the mean dose to 1 cc of the rectum was 25% of the prescription dose, which is substantially lower than what we normally would expect. Mean dose to 2 cc's of the rectum, 20% of the prescription dose. So basically, and the volume of rectum in really all of these patients receiving the full dose was basically nothing. And so the potential advantage here of further reducing the volume of rectum exposed to these high doses was achieved. And these are these rectal parameters. When we looked at patients with spacer and a consecutive group of patients prior to that, a year or two before, where this was not FDA approved and we were not utilizing the spacer, there were substantial improvements in terms of the overall rectal metrics, dosimetric metrics, when a spacer was delivered compared to not. And overall, the patients who had the spacer placement, as we had reported, had relatively low rectal-related toxicities, as shown here. And interestingly, no grade 3 toxicities, as in contrast to the ASCENDE-RT trial, where these toxicities would have emerged. And so there are many ways to reduce the volume of rectum: careful planning, intraoperative planning as well. And I think this is adding another enhancement in terms of our ability to deliver any kind of radiation with a much greater degree of conformality. And so in our dose escalation study, which we recently reported on and I discussed on Friday, as we moved from 32.5 gray and 5 fractions to 40 gray, and 40 gray has now become our routine dose for SBRT, we have treated 280 patients with just SBRT monotherapy with a hydrogel spacer. And I'm just going to share with you some of that data as well. Here in the group of patients that we've treated with a hydrogel spacer with SBRT monotherapy, the incidence of rectal bleeding, 0.7%. All grade 2 GI, 2%. The follow-up here is about 2.5 years. So we still need longer follow-up. Incidence of grade 2 urinary toxicities, low as well. And this we are soon submitting for publication. But what was most interesting was that in a consecutive group of over 500 patients treated with SBRT monotherapy at our institution, when we performed a multivariable analysis and looked at GI toxicity, with various parameters looked at, such as the age of the patient, the utilization of hormonal therapy, the prostate volume, rectal spacer turned out to be a significant variable associated with reduced GI or rectal-related toxicities. But interestingly as well, which sort of was borne out by the randomized trial reported by Hamstra, when we looked at GU toxicity, there was also a significant benefit in terms of the hydrogel spacer utilization for reducing grade 2 urinary related toxicity, which is sort of puzzling, and we're in the process of really doing some geometric and dosimetric analyses to better understand that. Is it possible that we are seeing, as a result of the placement, less dose to the urinary, the urethra, or less dose perhaps to the bladder neck trigone region? And so we are looking at that right now and trying to analyze. But it appears that from a number of publications, there may be some benefit for even reduced urinary toxicity. And Hamstra also had reported the reduction of sexual-related dysfunction among those patients who have had the hydrogel spacer, suggesting possibly lower penile bulb doses, but I think this has to be validated also as well in future trials. And when we look again at the spacer, here's the rectum, the prostate CTV, and here's the dose clouds. Again, we are seeing substantial reductions in the anterior rectal wall dosing with obvious placement or separation here between the prostate that we target, the CTV, and the rectum. So overall, we've treated over 1,000 patients with this hydrogel spacer placement for either brachytherapy-related treatments, SBRT-related treatments, and the like. We have not observed any significant toxicities associated with the actual placement. In less than 5% of patients, because of either fibrosis in the perirectal space, there's a lack of successful hydrodissection, and these are cases where we would abort and not place that if we're running into resistance when doing the hydrodissection. And 10% of patients immediately experience some rectal fullness or mild perineal discomfort for about 24 to 48 hours, generally ameliorated with anti-inflammatories. Additional clinical scenarios, the setting of salvage radiotherapy, which I alluded to. We have treated about 15 to 20 patients with salvage LDR brachytherapy after external beam radiation failures and the placement of a spacer. And I think in this group where there could be more fibrosis as a result of the prior treatment, spacer placement may not always be possible, and we say that in approximately 30% of the patients. Similar findings have been also reported as well. And we have treated, although I've been very reluctant to treat anybody in general with inflammatory bowel disease, even those who have had remissions of inflammatory bowel disease for years, I have been reluctant to treat them because we've seen some reemergence of IBD symptoms when you give any form of radiation. But this, at least if you could have a successful separation of the prostate and the rectum, would allow for potentially safer really application of high-dose radiation. So here are my conclusions. Dose intensification has been shown to be important for high-risk disease, and this is one of the major themes of this symposium. But it's clear that there is associated rectal morbidity. Not very high rates, but they're definitely out there in the 10 or 15% range based on randomized trials from the Hypo-fractionated series. The hydrogel spacer consistently helps facilitate significantly reduced rectal doses for ultra-hypofractionated regimens, and we utilize this as well, in particular for combination regimens or for brachytherapy as well. Early results demonstrate minimal late toxicities. Clearly, we need to follow it. What's very encouraging is that the randomized trial, even with conventionally fractionated external beam radiation, where normally we say in 2019 does not confer a high incidence of rectal toxicities, even in that cohort, it was demonstrated level 1 evidence of reduction of side effects and improved quality of life. And one point that I would leave with you, and again, it's to a degree speculative, but I think we need longer follow-up, is that when any kind of radiation, we know that there is a risk, albeit low, but certainly a risk of secondary cancers associated with the radiation. We're very mindful of that, especially in younger patients who are treated. And now the reduction of volume of rectum exposed to high doses could potentially reduce the incidence of secondary cancers by really minimizing and, in some cases, eliminating any kind of meaningful dose to the rectum with the spacer placement, which dissolves after a couple of months. And so I think it really is an important and helpful adjunct to our delivery of high-dose radiation, and longer follow-up will hopefully be there in the next couple of years to further demonstrate reductions in late toxicity utilizing this important adjunct. Thank you very much for your attention.